So I think we'll go ahead and get today's call started since we have a lot to cover today. I'll just briefly introduce myself. I'm Maria Monroe DeVita, and I'm with the Northwest Mental Health Technology Transfer Center at University of Washington. We'll get into more introductions here in a minute. Apologies to those of you who tried to join us last month. We had lots of things happening that were kind of interfered with having that webinar, including some terrible weather on the East Coast, many teams that were impacted by Omicron, either directly or just affecting your staffing or students that you have at home doing remote learning and learning, that for the first time. So lots happening. So we're holding today's webinar, and then we're holding another one in a month. So just a quick overview of our agenda. We're going to do just our brief intros. Our special topic today is working with individuals involved in the justice system, and we're excited to share with you a group of panelists from 4 different states. Then we'll have what we call open mic time, which means that we'll essentially have about 20 or so minutes where you can actually raise your hand and we'll unmute you and ask questions of the group. You can also put that in the Q&A box if you don't want to necessarily verbally say it out loud with others, but it's kind of a fun thing to be able to liven this up, which I think is sometimes not something we're used to with these larger webinars. So I'll get into that in a minute. And then just again, a reminder that we're doing back-to-back months this time since we missed January. So our next one is on March 7th at the same time. And then for this contract year with SAMHSA, then we have 2 more remaining meetings, and we'll talk more as we get closer to July about kind of what we'll be doing into the next year. Quick just housekeeping stuff I want to let you know about. So due to the large audience, you're all muted. And so you're not appearing on video. The chat box and the QA box will be visible to everyone, however, unless you decide to just put it to the panelists and the hosts. The presentation is being recorded, and then we'll be sharing a recording of the presentation in the next couple of weeks. If you're experiencing any technical issues, go ahead and send a message to our staff in the chat, and we'll attempt to assist. And then there may be times where we ask you to just share a response or feedback on something, or if you have just a general comment, those can go in the chat. But if you're looking to actually get an answer to something, that's where you would put it into the Q&A box. And so you should see those. There's a chat, there's a Q&A. It looks just like that icon right there. That helps us to track what kinds of questions were answered, and it also helps us to prioritize which of those we'll say aloud, or we'll put the answer into the Q&A in the response section. Please, again, if you have any questions, though, don't put them in the chat because we can't actually copy and paste them in, so we'd have to ask you to put those in the Q&A box. And then just brief introductions. I introduced myself briefly earlier, and we'll turn it over here in a sec to Lorna Moser. We are both trainers and content developers for assertive community treatment nationally, and we've done some work internationally. We're co-authors of the Tool for Measurement of ACT, which is one of the more recent ACT fidelity tools. We're both licensed psychologists, and you see a lot of other things here sort of listed. And I'm also affiliated with the Northwest Mental Health Technology Transfer Center, which is co-sponsoring these calls, and we serve the Northwest region of the US, including Washington, Oregon, Idaho, and Alaska. And Lorna, turn it over to you.
Yeah, hi everyone. Glad to be back and saw a lot of familiar names. It's really cool using Zoom, unlike how we used GoToWebinar in the past, being able to see where everybody's from. You guys literally represented the whole United States. And I'll say, I saw that we have a guest here from Norway, which I'm thinking it's got to be 9 or 10 o'clock at night over there right now.
That's commitment.
So it is commitment. So I'd be choosing Netflix and you're choosing us. So thank you. So yeah, we pretty much have been doing this now for nearly 2 years, and it's been a great pleasure to be able to support you guys as you do such hard, challenging work. So
absolutely. And so I think with that, speaking of hard work, we're going to go ahead and transition to our panelists. For about an hour or so. We're going to kind of dig into this topic, and I'll turn it over to Lorna for that. And then, as I said, we'll shift gears and have some open mic time that can be on other topics that you want, feedback on, or to compare notes on, or ask questions about. So we'll make sure we have time for that later.
Great. So my panelists are welcome to come on the video, and I'll do some introductions here. We have one that is calling in. So at times you may hear the phantom voice coming in, which will be Liz Middleton joining us from Oregon. So who you have here is Dr. Steve Harker is coming in from Minnesota. He's a psychiatrist and has been doing this work with ACT for many, many, many years, well experienced, has done a lot of collaborations with Maria and I over looking at aspects of the Team ACT, and is a trained Team ACT evaluator himself. He has transitioned into doing more work with a forensic ACT team in the Twin Cities of Minneapolis and St. Paul. Robin Wheeler, who is also up on here, is also from Minnesota and is a registered nurse with 15 years of experience working with people with serious mental illness, including working with a newly developed forensic ACT team in Minneapolis. Both Dr. Harker and Robin are working as part of a study that is looking at implementing FACT by the developers of Forensic ACT. So they're part of this unique experience too. And then also we have Randy Plant, who's from Norfolk, Virginia. Randy has experience of many years of experience intersecting and working with the criminal justice system, and helped take a standard ACT team in Virginia and build this extension of forensic work within the team itself. So in Virginia, they did a unique implementation with standard ACT that we'll hear a little bit more about too. And now I believe, Randy, you're the program manager, team leader of that team right now.
That's correct. Yep.
All right. And then Liz, who's joining us on the phone, is a licensed social worker, and again is coming from Oregon, where Liz is the FACT team leader of a team that's been operating for about 6 years now. So we had the pleasure of meeting these folks to get to know what they've been doing within their program, and had put together some questions that we typically expect that you all would be curious about. If you can go ahead to the next slide. So Maria and I have been having various hosts come and address many different topics these past 2 years. One topic that we haven't really delved into that we know is really relevant to all of you is how to best support and work with folks who are involved in the criminal justice system. Now, we have the specialized adaptation of forensic assertive community treatment. And so we're going to hear more about how that is similar and different than standard ACT. And also be thinking, even if you're a standard ACT team, what are some possible takeaways that you could be taking and integrating within your own practice to basically better support the folks you're serving? Because on previous surveys, about 15% on average of people that are served by a standard ACT team also are involved in the criminal justice system. So we know that there's a need there as well for standard ACT. So like ACT, FACT provides services that are client-focused, community-based, time unlimited, use of a multidisciplinary team. The services are intensive, and there's an attention to continuous engagement. While FACT adds this forensic component, providers really are working to ensure fidelity to the overall model. That is something that the originators really focused on when they developed their own fidelity tools, is to preserve fidelity to ACT with these additional components. And so some things that are different from standard ACT is this increased attention to criminogenic risk factors and needs. There is a lot more partnership and collaboration with the criminal justice system, and that can be different partners that are in the field, which we'll hear about more from these folks. You're serving people with serious mental illness, but part of the eligibility criteria is really focused on people who are part of a criminal justice system, or they're involved in the statutory system around commitment to receive services. Also, you're going to see a little bit more where sometimes the teams are really trying to sort out how to use the leverages that are hanging over a person's head when they're kind of in some ways being compelled to some degree, or not, that's how you kind of frame it, to receive this service to avoid something else that they don't want, like jail again, or going back into a hospital. So having to navigate those relationships too. So you can go ahead. And I'm gonna, when we have this in motion, we're gonna put in the chat a link to SAMHSA's very helpful description of forensic acts, so you can read more about it on your own as well. So with that said, I'm gonna start off asking the question about who are you serving? I was reading recent literature that was published by the founders, Dr. Lamberti and Dr. Weissman, around how you define and measure forensic act. And one thing they said was, when you look across teams that call themselves a forensic act team, they pretty universally share in this idea that you're enrolling people who have a serious mental illness. Where they differ is who is it in terms of a criminogenic component. So the teams vary greatly in terms of how serious of an offense it was. Are they not guilty by reason of insanity? Are they being diverted out of a jail system? Are they linked into a mental health court system? So that's where a lot of the variations seem to come from. So we want to hear a little bit more from our panelists around who they're serving. So I may start here with Dr. Harker. How would you describe who you're serving? And Robin, I think you guys probably share some similarities here too, since you're both part of the study.
Yeah, so like you were saying, yeah, I've done not forensic act for 17 years here in Minnesota. And compared to that population, the fact population is different in a number of ways. One, I think we're getting our referrals out of corrections, and the paperwork that we get is much less thorough at times. And if it's coming out of corrections, we see false labeling and malingering sometimes in people who have schizophrenia. And so just in our screening process, there's also really, really high levels of trauma. That's pretty typical for ACT, but this is just even more. So we end up with a population that I just gave a talk on Forensic Act and looked at 14 people on my schedule for December 10th. And I think 13 of the 14 had complex trauma histories. 11 of the 14 had severe comorbid substance use, which is not atypical for ACT, but 7 out of the 14 were actively using meth. And then a little more sociopathy. So I think in terms of who we're serving, this population, when we're taking people, we're trying to take people with psychotic disorders, but sometimes we're guessing because of the heavy meth and trauma. If you get complex PTSD with heavy meth use, it can look a lot like schizophrenia. So we end up with a population that's a lot more homeless because of the felonies, much more difficult to find work, higher rates of meth use, a lot higher rates of complex PTSD. So the population's harder to find and harder to treat for those reasons compared to typical ACT for me.
Yeah, and as you said, I think we serve a really similar population, and our model and teams are built fundamentally very similarly, so that all rings true. Much higher trauma, much higher substance use, higher homelessness experience. So I concur with all of that.
So one thing I recall that you shared, and I'm going to be queuing you up, Liz, just to be prepared. One thing that you shared, Dr. Harker and Robin, is that by way of how you're getting referrals, you don't have as much information on history of what's been going on with mental illness and symptoms. So you're kind of sorting out, is this mental illness or is this drug-induced, life-induced factors? So you're almost like an investigator trying to keep figuring out what's leading to what. Liz, if I recall, you kind of feel like you're getting referrals with much more information. You're kind of more secure in knowing that they have established serious mental illness. Can you share more about who you're serving and where you're getting your referrals?
Sure. I just also wanted to just clarify that I now work for Oregon Center of Excellence of Assertive Community Treatment Teams as of, January, late January, but I did work with the FACT team in Multnomah County, Oregon, since 2015 until January of this year. So just, having that perspective. So the folks that were served primarily had a diagnosis of schizophrenia or schizoaffective disorder, lots of co-occurring issues with substance use, as well as histories of trauma. Folks were being referred from mental health court, forensic diversion, parole probation. So definitely a combination of different referral sources in terms of the criminal justice involvement. But yes, I would say, folks were appropriate for ACT level of care. Medical necessity was already reviewed by our CCO in terms of making sure that the individuals were ACT level of care appropriate. And then, of course, it's an ongoing, uncovering of history and other factors in addition to the psychosis that we were seeing.
Great. And congratulations on your move. You're working with an awesome team over there with Heidi.
Yes, I am. Thank you so much.
Randy, if I recall, something that you shared that was unique about your program is you tend to end up serving more people who are coming onto the team under a not guilty by reason of insanity.
Yeah,
So can you share a bit more?
Yeah, that's correct. And I just want to share first saying that we currently have on our ACT team 91, 31 are FACT. They have a forensic history. Of those 31, we currently have 6 that are NGRI, and we get those out of the state facilities. And with those folks, we usually see them 7 days a week. Some we see 5 days a week. We go to their court hearings with them. Sometimes there's 6 months, sometimes they're 1-year reviews.
Yeah. Yeah, I think something that we'll probably be rounding back to or anticipate the audience will care about too is the higher risk somebody comes onto the team, whether it's through criminal justice or through a commitment process, tends to end up involving much more oversight by both the ACT team, but also any other type of body that may be overseeing things. The court, the judge, probation officer are all much more paying attention to how things are going. Great. So I'm going to move us to the next question. Keep the ball going. So one question that we may have from the audience is this question about how voluntary is enrollment, because you would think that in some ways you end up serving a whole lot of folks that they picked the least worst of their options, and maybe their enthusiasm for engagement is just not quite there. So can you guys share a little bit more? Let's see. Let's go ahead and start with Randy, since we're just hearing from Randy. So how voluntary do you think people feel like their experience is?
Once they get used to our services, they get used to our staff, or they get used to the psychiatrist. Most of them like us, and they cooperate. And then we have those that don't cooperate, but we continue to attempt to engage them every day.
How about Robin and Steve?
Yeah, I was thinking the same thing, that, obviously if someone's coming out of corrections and before they're getting out of corrections, we're doing a screening over Zoom, they're going to want to work with us. And that's very coercive because they're still locked up and we're the door out in their mind. But once we start orienting them to how we operate, asking them what their life goals are, and focusing on those things, it becomes more just cooperative. we have people that the probation officers attached to our team for the most part, if they're on our team. And then when they're going off probation, they're often asking then, can we keep working with you even though I'm off probation? So you see this transition over time for the most part.
Yeah, and I would agree with that from our perspective. The vast majority of time when we have limited engagement or buy-in from the folks that we serve, it has more to do with barriers to finding them or serving them or other sort of barriers. It's not necessarily a lack of desire to work with us. We have pretty good voluntary, I mean, it's all voluntary for our teams, but we tend to see it go pretty well. The majority of the folks that we serve, if they exit the criminal justice system kind of path and graduate, continue on with us. Not everyone, but the majority. We have pretty good engagement, though there are other barriers to serving folks.
Good. So that's giving another subtext question around when people complete whatever it is they're under that got them onto the team, they can continue with you truly on a voluntary where there's no pressure from an outside system. They can continue to work with you.
Yep.
Great.
At least for our team.
That as well.
Yes.
One question I wanted to specifically ask, I think with both Robin and Steve Harker, Dr. Harker, I'm used to calling him Steve, so not to confuse everyone, and possibly with Liz too, that you both are intersecting with a probation officer as part of the role. And sometimes you're able to clearly differentiate what is the role of that probation officer or not. It probably isn't as easy to clearly differentiate. What's the role of the team versus the role of the probation officer? I can imagine some people are a little concerned about being involved in fact because they don't necessarily truly trust what's being shared to who. And an interesting tidbit I read in the literature was that probation officers who operate very black and white in terms of like calling people out on violating whatever terms, not surprisingly, those folks have higher rearrest records. Probation officers who are part of problem solving, they want to see people succeed, they have a reduced rearrest for the people. So their role is really key in this too.
Yeah, we had a situation just this Friday that there's a person who, due to command hallucinations, attacks people and is arson, who's been out recently and moved to a kind of a sober house, but has nothing to do. So the probation officer wanted him to go to daily 3 to 4 hours of outpatient treatment. But there's a lot of drug dealing going on at the treatment, which is really causing him to have cravings for meth and tempting him because he's seeing it there. So in that case, it's easy to call the probation officer, and he right away is like, yeah, it'd be a lot better if he was volunteering or something else. And so we came to an agreement to focus on other ways he can structure his day really quickly and get out of that kind of probation requirement. In general, they meet with us on a weekly basis or more via Zoom, via our team meetings. So they're in the flow of things, and we're always talking about those kinds of things. Sometimes we need more leverage with a person, and they can help with that. And then oftentimes when there's a court issue coming up, they can be there to help get the point of view of the fact team to the court in terms of that stuff as well with the judges.
Yeah, and one of the few ways that Dr. Harker's team and our team operates a little bit differently is we work with a wide variety of probation. We had started with a smaller core group of probation officers, but we actually have kind of expanded and work with probation officers across several different roles and capacities in the criminal justice system, where I think, Dr. Harker, your team works with just one or two kind of more core probation.
Yeah, for the most part, yeah. It's broadened a little, but for the most part, yeah, we have a couple that we work with a lot.
And we still have a core couple, but we do have a broader relationship across the probation system. The one thing that we have in common is, for the most part, with the exception of one or two people I can think of, they requested to be working with FACT clients. So that kind of self-selects the population of probation that we're working with, that they are already invested in maximizing the supports for the people that they serve. They're really invested in that collaboration. And so in general, we work with some really great probation officers who already kind of are wired that way. And so that tends to self-select probation officers who have that buy-in into this service. And we have really great relationships for the most part with them. As that probation officer pool that we're working with opens up a little bit, we're kind of learning the nuances of different personalities and different roles for that. But in general, it's pretty collaborative.
Great. So I'm going to go ahead and turn us to staffing, because I think you guys have some interesting differences of how you have staffed the team. And I'm going to actually prime Liz to share a little bit first. What is
Sure.
Sorry, really quick, Lorna. This is just a really quick question because it does fit with just the last question. So I just didn't want to get too far away from it. So we did have a question out of Oregon just to clarify population. I think it'd be helpful. Randy mentioned NGRI, and do you also serve folks who are incompetent to stand trial, or, I think in other states it's known as other things like unable to aid and assist, like it is in Oregon?
We do here in Norfolk, yes.
Others? Yep. So Virginia,
incompetent, non-restorable.
Yep. Okay. And then what about reentry from prison?
Here in Norfolk, I actually went into a correctional facility to interview a guy. So, and we have 3 currently on the FACT team that served time in prison, and they're now part of our team.
Okay. Any other significant?
For us, that isn't a major pathway for referrals, but I have one on my caseload that I know for sure came directly from prison as their first kind of most recent offense or time that they've served. But the vast majority of the people that we serve have had prison time, even if they're not under that sort of parole in the moment. But yeah, we serve kind of equal opportunity, all of it.
Yeah, same.
Yeah. Okay. Thank you.
All right, Liz, can you share a little bit about your team, the team staffing with the team that you were leading?
Sure. I didn't answer the previous question, so I can add that to it as well. But so the team I was working on definitely a voluntary approach to providing services. Although sometimes folks are feeling quite unsure about whether or not it is really voluntary and who we're working for. So we're very intentional about focusing that we are your team. We are developing a therapeutic alliance with you. In terms of specialties that were really helpful for that, the peer wellness specialty is extremely essential to creating that safe space with folks, to help them to acknowledge that we are not part of the criminal justice system. We are their treatment team, but we can work together with you to help you to reduce your risk and to reduce recidivism for sure. And we encourage people to sign releases of information for their parole officer, probation officer, what have you, whoever they're working with that's a part of the criminal justice system, although it's not a requirement for treatment. And together we can work out a way that it will be helpful to you for us to talk with your probation officer or parole officer, what have you, to try to help leverage some helpful resources that could address your needs. So that's kind of the recovery-oriented approach that we took with folks, and that also was along with recovery-oriented language that we would model in conversations with criminal justice folks, and had good partnerships with them as well. And we did not have a probation officer on our team, but we had really great working relationships with Department of Community Justice here in Multnomah County, and that continues. In terms of specialty on the team, I would say one of the areas that is unique for a forensic act team versus a non-forensic act team is to have the forensic psychiatrist being available to provide trainings to team members, consultation to team members, and to the community, to be able to provide risk assessments for our participants, and just having that specialty lens to share that along with the team. In terms of the other specialists on the team, there's mental health professional QMHPs, support employment specialist, peer wellness specialist, SUD specialist, just pretty much all of the regular specialties that are required for any ACT team. And now as an addition, there is a housing specialist working with the team, which is really exciting.
Great. Now, I've heard some of you speak to having a court liaison, somebody who's appointed as a court liaison. Can you share a little bit about what's their role? Like, what is the purpose of that role?
Here in Norfolk, Lorna, most of the courts, we have specialty courts, we have a mental health court, we have the mental health docket, and that's usually me attending those. However, the mental health professionals and case managers, they do take their fact people that have to court. They do take them to PO appointments. So there's involvement across the entire team. But as far as the specialty courts on the mental health side, I'm usually the point of contact on that with the judges, the Commonwealth, and the public defenders.
Thank you.
Mm-hmm.
And for us also, we have a pretty seasoned team. That's one of the nice things about our team. We are newer as a team under the model of FACT, but most of the people on our team have been around for a long time in some capacity of the ACT model or criminal justice or our mental health services in general. So we do have a court liaison whose name is Jim, and he's just phenomenal and just works really closely with attending court. He knows all the judges, the attorneys, and just can be really a present person in the process. Michael, who is my team lead, who I see popping up on my chat, is also on and kind of is very similarly able to navigate that system really well. But the nice thing is I think that our whole team is pretty comfortable with the criminal justice system. So even I, as a nurse, attend court pretty often, or even a little bit more often when it was in person. And so we have a role, we have kind of a backup with Michael, who's very competent in that also, but all of us actually are really quite proficient in being able to pop in if needed.
Yeah, relationships are so key. And it's just like a lot of positions on the ACT team. When you have somebody appointed to be the one going out there and developing and continuing those relationships, just coordination and communication just gets so much better. Another position that we sometimes hear about, and I think I may have heard Liz mention this, is somebody who would be a forensic peer specialist. So somebody who has the lived experience of also being in the system themselves. And as we know from the value of peer specialists that come from a variety of lived experiences, there is something about the credibility and the ability to connect with somebody by having that mutual respect and shared experience. So if you have a forensic peer, could you share a little bit more about how they're used?
So this is Liz from Cascadia FACT team. At different points in time in the history of the program, there have been peers that identified as forensic peer specialists. And then at times there haven't been. But I can just, say that having someone that has lived experience is very powerful. And if you're able to recruit someone that has that experience and that is, working in that particular type of role, I think that's extremely helpful. But just having, a really awesome peer is extremely helpful, of course, even if they don't have specific forensic personal, lived experience, but it is great to have that perspective.
Yeah.
Yep. I would add on our team, our peer specialist speaks to us of growing up in a family where there was a lot of criminal drug activity going on, and her ability to ferret out what's really happening with some of our people that are in similar circumstances and build trust and help them with all the pressures that being in that kind of a family or social system comes from has been just invaluable.
Yeah.
Here
Great.
in Norfolk, Lauren, our peer specialist does not have forensic life experience. However, we do have a tremendous peer panel group within the CSB, and a few of them have forensic life experience, and they have talked to some of our folks.
Great. And CSB is Community Service Boards, which is basically a name for some of the agencies in Virginia for the rest of the folks. All right, so I'm going to go ahead and move us to the next question, which you already were starting to tip into this a little bit around service coordination. Not very different from just standard act. We are intersecting with a lot of systems, but criminal justice in particular is a big system to navigate. And you've already given some examples around probation officers and what their role would be, and the importance of relationship building, which your court liaisons may be playing some role around that, or whoever on the team is oriented to doing that work. So let's talk a little bit about what things your team is doing around service coordination. So assessing and identifying, meeting individual needs, which may be further complicated with criminal justice involvement. So how are you intersecting with other components of the system? I actually may start with Randy, because you had some neat examples of how you really cultivated a lot of relationships with community partners that are intersecting with the people you're serving. That's correct, Lorna. We're lucky. We have a wonderful relationship with the Norfolk Police Department, a wonderful relationship with Fire and Rescue. They know who our people are out there. The courts know all about the ACT team. They know all about the FACT team, the public defenders and defense attorneys. They know all about us too. And I found it to be very important to try to maintain positive relationships with those other city agencies, because like I shared last month, I go to court, even law enforcement, they don't want to put the mentally ill in jail unless it's something really serious. They don't want to do it. Or the judges don't want to keep them in jail unless it's something really serious. Yeah, so it sounds like from what you've shared and just shared now, like there's more of a shared mission that we need to appreciate and cultivate in terms of everybody working closer together to try to help people avoid these settings and succeed in living more in the community. Right. That's correct. How about others? Examples of where, Steve, I think that you spoke to kind of an effort around really having to work on keeping your team anchored in what Liz spoke to, a recovery model. I mean, this is FACT can be a model that drifts a little bit down the road of being a little coercive, a little paternalistic by design of who you're serving that's unique from a standard ACT team. So how are you doing things to try to keep people more anchored in a recovery perspective?
Yeah, and that's always the complication for a number of reasons. One example, it's almost like with some of our people, their lives are so scattered, it's much harder to establish personal goals that you can relate to through different appointments because they're so in the moment. And it's more getting a person-centered philosophy going and trying to apply that to more fluid situations. That's been one of the bigger challenges. For example, one person that we have with high levels of meth and very disorganized thinking, but he told me up front that he felt really good once when he was going under general anesthesia for surgery, and right before it hit, he had no worries in his head. So he always wants to he's like, I'd like a med or a life that would help me not have worries, like right before I was going to go unconscious from general surgery anesthesia. And so he can go back to that pretty much no matter, whenever we're talking, he remembers that is like what he wants. So sometimes we're just modifying things in that way. But in terms of the bigger questions, coordinating with the justice system, I think a big part of this, a great time to plan and do recovery stuff is when actually they end up in jail or prison if they're hard to find or really high all the time. So it's we're still working on, especially with COVID, it kind of wiped it out, but trying to have better communication when they're in jail, knowing they're in jail, and then being able to communicate with providers in jail. So right now we have a meeting coming up with the Department of Corrections to try to improve that. At our local jail, there's been some issues lately because of staff turnover with them that we're going to have to address with another meeting. So it's kind of this personal level, but then also trying to find those points in the system where you can communicate in a good way about person-centered planning and their own recovery goals, and trying to get to them when they're in those places.
Yeah, and when I opened this up, I was almost pointing us towards coordinating with external bodies, but the internal coordination within the team and how your daily team meeting is used to really facilitate that. If I recall, Robin, your team is still younger in terms of doing facts specifically, and you're enrolling people still in this early engagement, high need. You spoke to kind of feeling like you're still a little crisis oriented, and that coordination is like literally paying attention, like who has seen who hasn't seen them for over a week. Are they in jail? So can you speak a little bit about what that looks like?
Hey, someone I've been looking for weeks. I found out from an email from my team lead this morning has been in jail for a while, and we didn't get notification. And I have been searching the community for that person. We have a little bit stronger relationship with one of the jails than we do the other. But again, as Steve was saying, we're kind of working on that. Yeah, and I think I spoke to this a little bit earlier too. I don't want to discredit the barriers that the traditional ACT clients face, but I think with our substance use and our homelessness and the trauma and difficulty finding felony-friendly jobs and stuff, we just tend to have a lot more people kind of facing logistical barriers to engagement or to really being able to get to Maslow's kind of next level of needs. And so we do, especially at the beginning, but kind of ongoing, end up spending a lot of time of just stabilizing and really just kind of getting to some of those basic needs. I think the whole country is probably facing this, but Minnesota is just in a really, really desperate housing shortage, and especially for people that we serve who have those kind of criminal backgrounds and substance use. And so it does seem like we're spending a lot of time in stabilization and early engagement. Not to say that there aren't successes, and we have a ton of those too, but I think that is indicative of a newer team and also some really big significant differences in the population that we serve, and some of the real common barriers that they face trying to navigate the world.
Mhm.
The other thing that we spend a lot of time talking about within our team are incentives and material goods, because as she was saying, that hierarchy of needs, and this is a population that has been deprived of resources usually their entire life. So their view of us is that we have resources, and it's really important to be strategic with that, because it's hard to get the trust and then go into a treatment therapeutic relationship that involves more abstract ideas and trying to help them problem solve and build skills. It's harder to shift from I need some resources to get boots or a coat to that stuff with this population, I think, because of all those factors. And so that requires a lot of team conversation, coordination about giving out things to people in a strategic way, but then trying to bridge it into therapy and treatment.
So Maria, I was going to pause before moving on to see if there's any topic.
Yeah, we've got quite a few. So there is a question about how many of your programs require screening, referral, and follow-up for social determinants of health services specifically. That's something more formally addressed in your teams. Thinking about contributors to where they're at, anything like that.
Can you just phrase that question one more time?
Yeah, so the question is, how many of the ACT programs represented by the presenters require screening, referral, and follow-up for social determinant of health services? So social determinants of health, contributors to where they're at right now in the criminal justice system, housing. I mean, I feel like there's some of this is stuff you've already addressed, but it sounds like it's more informal versus formal. Like, we know that housing is a contributor, lack of housing, for example, or
yeah, I guess I can't speak to any formalized survey, but it is so prevalent that it is something that we can't not see and not address. But then there are barriers that we have in addressing it. So housing's a great one. I don't know what our current statistic is, but the vast majority of our team is unhoused at the moment. And so, that it's almost an assumption that there are major determinants of health issues.
Yeah, and I almost feel like the ACT comprehensive assessment was ahead of its game in this regard, because it was always paying attention to social determinants of health. I think the catch is collecting the data can't stop there. You have to take the time to understand and interpret it to then say, now what do we do in terms of support?
Right.
Yeah, and I think that's where the individualized treatment planning comes in is, what is most important for the individual at this time? What are, they most motivated to work on with us, and trying to, join with them there. So we're addressing the things that are important to them, and housing is definitely a need that many of our folks have, and we want to make sure that we're addressing that. And a lot of times that's where the collaboration begins is, yes, you have this need, we want to help you with that need. And that is going to be one of the, primary things that we work on together to develop this trustful relationship.
Right.
We also had a question. Oh, go ahead, please.
Yeah, I'm sorry. Yeah, we're very lucky on the fact team in Norfolk, knock on wood. Of the 31, we have one that is homeless. So,
Wow.
However,
That's great.
She will go out and go to the local emergency room and destroy property to get taken into custody so she can be in jail as opposed to being cold and out on the street. Yeah. That's I've known her for a long time, and it's been a pattern for a long time.
Yeah.
There's-
I have to say, homeless in Minnesota sounds way worse than homeless in Norfolk.
Yeah,
Yeah.
Yep.
we got a good homeless program down here also.
Anywhere though.
Yeah.
Yeah. Well, in terms of local stepping up efforts, are you familiar with the program Stepping Up? Kind of what that is? I think we might need to get, no one on the call is. Liz, are you? Because this came from one of your team leaders in Oregon.
The Stepping Up program, I'm not familiar with.
Okay.
Sorry.
Okay, no, that's okay. And of course, I'm asking this question on behalf of someone else who knows about it. So I think the question was just if your teams exist because it was in coordination with local Stepping Up efforts. So Doug, I know you posed that question. So if a little later you want to raise your hand to potentially share, or you can put it actually in the chat what Stepping Up is. And then do any of you coordinate with like mobile street response or crisis response services? And if so, what does that look like?
So for our team, actually, they are duplication of services. And so in theory, we should be able to step in instead of the mobile street responses. That isn't always how it works, because oftentimes when the folks that we serve are in an environment or in the community, someone will call those because they're familiar with them and may not know that we're involved. And so they do sometimes get involved. If they can ascertain that we are connected, they will reach out to us. But we actually don't intentionally collaborate with them. So it's more kind of like sometimes they'll end up getting called in before someone knows we're involved. But yeah, we don't intentionally collaborate with them.
Yep. Same with us. In our county has a crisis mobile team, but we don't collaborate with them very often. We generally end up calling emergency services, ambulance with police backup usually, and we're there as well.
Got it. Okay. And Lorna,
Yeah, and then,
oh, go ahead.
oh, sorry.
Please. Go
I was
ahead.
just going to say for the folks that I'm familiar with working with, there's the crisis alert that is active for all the participants of the program indicates if there's a call that goes into the crisis line or a call that goes directly into the mobile crisis team, that those entities contact the FACT program as a first step to, coordinate care to make sure that FACT is involved in taking the lead on addressing whatever need is presenting itself for those participants. So there is some collaboration that goes into working with the mobile crisis team in those kind of instances.
Great. Now, Lorna, there is a question about services, specific services or helping people in particular ways, but I know you were going to get to that, right, with the next one, or is this our last one?
This one will be brief, and then we're going to ask for some pro tips, which
okay, perfect. Okay, so this may be covered. I know there was a question about helping people with a felony find housing. So just kind of putting that out there. We won't ask it right this second. Well, when we get to the pro tips, I think we'll be coming back up.
All right, so the next one will be a brief one, but just the question is about anything you're doing unique around documentation or outcome tracking because you're a forensic team. One thing that may be relevant, Maria, if you can progress the slide, is sometimes if you're tasked with serving people that may be perceived or by definition of your eligibility criteria come with possibly a higher risk, because they're coming out of prison, jail, being diverted, or on a conditional release, that maybe really careful documentation is important to track what you're doing, what's their response, what's working, what's not working, because if something doesn't work out, somebody may be paying attention closer to what's happening. So you could share a little bit more if anything is different that you've noticed for your team. We encourage good documentation for all teams, by the way. It's more of, is this even more on your radar because of who you're serving?
I think sometimes emotionally, yes. I'm speaking to peers, so documentation is always a challenge. But I do think that especially when we get a case of the ickies, like something feels a little uncomfortable, I think as a team we try and highlight, and we're pretty good in team meetings to say, like, make sure, Robin, you document that, make sure you made a note on that. Who's going to take that on? Who's going to email the probation officer so that we have clear communication? We get into this question a lot on what our role is with orders of protection. Like, do we need to document that we saw someone in the presence of somebody that we know legally that they shouldn't be around? However, we're not the enforcers of that. And so I think a lot of times it's just dialogue and kind of reminding each other, especially when we feel like this is going a little different, to make sure we're documenting. But that's, always a challenge. But I think we do have a lot of dialogue around that.
Yeah.
Lorna?
Go ahead,
Steve.
Well, so two areas. We're kind of revamping our treatment plan system and starting to focus more heavily on, before we do a new treatment plan, reviewing the previous 6 months and what happened in a more structured way. So having a meeting before we treatment plan where we go over each goal in the last 6 months. And that's been important because so much happens over 6 months. And a lot of the time we're so used to risky stuff that we forget about very important things. So having a more methodical, let's look back before we move forward every 6 months, that's been helpful. But we're just starting to do that. The other thing is we have a tool that the probation officer does that we review kind of with the treatment planning review stuff. That's the LSCMI, which is recidivism risk. And it looks across multiple risk factors that include criminal history, antisocial behaviors, as well as how a person is using leisure and rec, what impact their family has, substance use. And so that score, if you do it every 6 months, you can see changes in area to area. But it's also just a good team management discussion because you're looking at, they're weak in leisure and rec. So what can we do in the next 6 months to help with that, to reduce the risk of recidivism? So it kind of makes you step back and look a little more at a broader way to change the recidivism risk.
Nice. What's the name of that again?
LS/LS/CMI.
Okay.
Yep.
It's a level of service case management inventory.
Okay. I read about that when I was reading the literature. So it's similar to the START, ones that really take a step back and look at those protective factors to beef them up, and then look at the risk factors that you're trying to tamp down. That's great.
Yeah.
Hey, Lorna.
Hey, Randy.
Here in Norfolk, as you know, the documentation component is vital. We put it on the ISP, and also with the 31, we do a lot of outcome tracking because a lot of our people that get trespassing charges, they won't get taken into custody, but they'll get a summons. And they don't tell us when they get the summons. So they don't show up for court 9 out of 10 times. So that gives them a failure to appear, which means they have two charges. So what we do here is we have a website that I check every 2 weeks to see if someone has a trespassing charge, when the court date is, so we can ensure to take them to court so they don't get a failure to appear on top of the trespassing. And then my teammates will come to me saying, so-and-so is not hanging out where they're usually hanging out. Can you check the jail? And I'll check the jail. And unfortunately, sometimes they are in the jail. But at least we know where they are, and then we can get get the ball rolling as far as getting a PR bond, talking to a public defender, maybe getting the case transferred over to the mental health docket as opposed to the regular court. So we do a lot of outcome tracking here in Norfolk.
Yeah, that's a great use of what is often a public system that's out there and available.
Exactly.
Yep. Tracking for these exact reasons, where something minor comes up, but they don't show up, and then something minor turns into something major.
Yeah, that's correct.
Can we go back to what Steve said just for a minute? We did have a question about just, going back to the treatment plan and aligning, the goals of the treatment plan and going back to them each, every 3 to 6 months. We had a question about, does your FACT team treatment plan roughly align with whatever the probation officer calls their care or probation plan, covering those criminogenic risk factors, or it's really separate? Is there any alignment with those? Between those two?
So we have and we got a new team leader and had some staff turnover, so this kind of fell to the wayside for a few months. But in general, the discussion about the LSCMI findings with the probation officer was done at around the time of the treatment planning meeting. So those ideas, the relevant ones we as a group came up with, were often incorporated into the treatment plan. There's not a formal aligning. I don't know that we see the probation officer's plan. We're following our own treatment plan, and they're part of the team, the probation officers.
Yeah.
So,
Okay.
Yeah.
Separate. Yeah. That makes sense.
Well, let's go to the last slide. I'm actually going to pick up with Steve because it's on topic with what you've been sharing around planning, which is to go back to assessment. So we're asking you guys to share some pro tips, things that you think other ACT providers, whether they're forensic or not, may benefit to hear from about. And one thing I recall you talked about is that sometimes it can feel a little hopeless because of the repetitive failures that you see with this particular population you're serving. But you kind of see promise of what you could take from that, if you could share a bit more.
Yeah. So I think what really helps me is the idea that at the end of the day, in any novel situation, I'm trying to reassess and go back, and even social history. If someone's in a jam, talking about their childhood, but trying to tie things together, trying to take bits and fragments of pieces, and continually reassessing, and then helping someone make a decision. And I always feel like if I've done a lot of assessment with someone and we've talked things through and I've helped that person make a decision today about something, then I can go home and feel okay. And the rest is up to that person. And so what I've found is the paperwork we get when we get them is scattered, as well as their ability to kind of tell their story. So diagnostically, psychosocial history, all these important things to helping them. You're not working with as much information up front as I'm used to. And then trying to find these points whenever they're clear to sit down and think about it. I'm going to try to get more history out of them in general about who they are as a person. And add that into the mix. And, so you kind of keep this building assessment over even a couple years. It's taken me a couple years with this one person in particular to figure out why childhood experiences led to the particular type of delusions they have, and why those delusions are so hard for them to give up as a way of experiencing daily life. So things like that.
Yeah. So I know, Robin, you spoke to how important it is to not overlook trauma. And Steve also spoke to complex trauma, and everybody else on here. You also shared kind of the importance of your role as a nurse and how that can help teams.
Yeah, I mean, when we kind of did this mock discussion a couple months ago, we could have spoken forever about some pro tips, but just purely from the nursing perspective, I think in general, nurses to nurses, are really extra collaborative. Like when I hear a nurse on the phone or when I get a nurse on the phone, I can get a lot farther than I can with some of the other providers in the world. So lean into your nurses to make relationships with the jail nurses, with the nurses in any system. And I'm just thinking of jails in general, is because I can kind of cut through a lot of red tape by just calling another nurse. And so sometimes, really often on our team, if we can't get a hold of someone or we don't know what's going on in any drug and alcohol treatment system or the jails, they're like, Robin, call the nurse. And like really quickly that camaraderie of nurse to nurse can be a really effective way to get some information. So that's just a pro tip is, get your nurses connected to other nurses and you can sometimes facilitate a lot quicker communication.
I'll open it up to Randy next. And then Liz, if you had pro tips, we'd want to hear them from you too.
Hey, Lauren, I think you're the one that used the phrase working together as one big city.
Yeah.
I think you sent me an email on that. And as I mentioned earlier, I think it's vital to have a positive working relationship with law enforcement, with fire and rescue, and with the court system, as well as the FACT team providing services to these people, prompting them to take their medication, taking them to go see their PO, keeping them in stable housing, because that's all important so they don't go back. So yeah. I like what you said in that email.
Yeah, I was capturing, kind of presenting that bouquet back we got from you, which was the efforts you've really committed to build relationships, because it is the community. Everybody's part of that community and they have a vested interest in trying to help this person.
That's right. Great. Yep.
How about you, Liz? So we're ending with pro tips. If there's kind of a takeaway you think is important for folks to hear, and then we should open to a little bit of Q&A time. I think we've been going on a little long here. Me, the facilitator.
Liz may need to unmute yourself. There was some feedback that we were getting from the phone. You're able to unmute yourself, Liz? I'm not able to do it remotely, I don't think. No.
The other thing is just the family involvement piece. And a lot of our people are still involved with their families, and they're often criminal. There's criminals in the families. And so getting to know the families, we've done more of that on this FACT team than in the last year. And it's been really helpful.
Mm-hmm.
Hello, are you able to hear me now?
Yes.
Okay, great. A very concrete pro tip that I have is, I know one of the other teams said that they have some difficulty knowing if their individuals are in custody. And so what we had learned a while ago is that you can actually use the VineLink notification system. It actually was developed for victims to be aware of when folks were getting out of custody or go back into custody. And so you can just sign up with an email to have an email automatically sent to your team when without identifying who you are, that you would like to know when the participant was getting out of jail or going into jail. So that's been really helpful, because then, the whole team is aware when they see that email that someone's back in custody, and then can start doing the coordination right away with the corrections health team. I guess just to piggyback on what everyone's saying about relationships, we had developed a monthly meeting with the local mental health unit, probation officers, and that was just really helpful in just maintaining that relationship and keeping the communication current and making sure that we're staying in our own lanes, but appreciating the lane of the other partner and being transparent about what role we're playing in being advocate for our participants. Yeah, I mean, I agree that like the specialty conversations really are very helpful with nursing, talking to nursing, social workers, talking to social workers at local hospitals for coordination of care and that kind of thing. Yeah, and then just, as much as you can, connecting with other like-minded professionals in the field, other forensic-oriented programs within your organization or in your area where you can share best practices and resources, training opportunities, and the such. That's about all I have to share on that.
This Vine link is amazing. I just pulled it up. I don't think I ever heard of it. How cool.
So that's national?
It is. And somehow it's connected, I'm guessing, to local county, city jails and everything somehow. I mean.
Oh, okay.
It's vinelink1word.com.
That could be really nice.
Yeah.
That's fantastic. Does anybody have a pro tip on assisting someone to get housing with a felony history? I know it's a tough one. We heard about jobs too.
Probably the only thing is have relationships with landlords or agencies, but that's so specific.
Right.
Yep.
Well, and as others on the call, any of you who have had some of this experience, feel free to that's a good thing to put into the chat to everyone so that everyone sees that. Because I think it's a pretty common concern for sure. What about, people had questions about suicide prevention protocols, and if any of you are using specific screening tools for that. Seems like probably a more, not just specific to forensic act, but just would be one that anybody really could benefit from. But if you have specific tools, you can also put them in the chat to share with others. What about working with halfway houses, recovery residential programs, or 12-step or smart recovery programs in your community? Any specific models you're using or using more of? I know, Steve, you said there's a lot of meth use. Any pro tips related to just, what you all are using, and that might be over and above what you might be doing in an ACT team?
Yeah, we're using a lot more outside services than I would on our other ACT team. And I just think that the number one rule there is to be in frequent close contact with those providers. There's so many things that with meds, substance use, the behaviors on site that you can help mitigate.
Yeah, I concur. It's collaboration.
We also had a question about, go ahead, please.
I was just going to say for assessing SI, suicidality, I don't know if anyone said the short-term assessment of risk and treatability yet, but that would be something to take a look at.
Yeah, I like that assessment tool too. The START, we trained and tried to get some ACT teams on board using it here in North Carolina.
That also takes into account violence risk assessment too, right? It's a mix of different
risk
assessments. Yeah.
It's homeless. I mean,
Both.
it's inclusive.
Right. I know we've used the Columbia just as a separate screening tool for suicide in Washington State. It's part of our comprehensive assessment. If people are endorsing suicidality, that's one of the tools we point them to.
Yeah, same in Oregon.
We do have a question. It's pretty specific, but you all might have some ideas on this. So for somebody who just got their fidelity review, it sounds like the RFACTS, which is the fidelity tool, right, for FACT teams. It seems like a few of the items are based on addressing or identifying criminogenic factors and ASPD symptoms. Do any teams have go-to tools or scales they use? The LS CMI sounds somewhat in line with that.
Yeah, I think we partner pretty much with probation to kind of help guide some of those assessments. I think we do our own as well, but that is such a comprehensive assessment that they are already doing, both on admission and kind of regularly, that is something we try and incorporate into our work.
Mm-hmm.
Yeah, I think for us, sociopathy is such a complicated topic because people that are traumatized and seeking drugs can look very sociopathic. So it's just a lot of frequent team discussions about what all the variables are and is there sociopathy actually? And it often takes a year or two to even figure that out.
Right.
And I agree with Dr. Herker, like, are we seeing the same things across all settings in time and space, or are we seeing certain of those risk factors or behaviors only in certain environments? And then we can kind of compare and contrast and get to the bottom of that.
Sometimes people clear and are doing well and the sociopathy goes away entirely, but sometimes it increases at that point because they're more clear-headed and revert back to that personality construct.
Yeah, very much that detective mentality that we spoke of at the beginning of this call.
Right. We do have somebody who has patiently been holding her hand up. So holding their hand up. Let's see. Deja, I went ahead and enabled. You can unmute yourself on your end. The last name is Spencer.
That was by accident. I kept accidentally clicking it when I was trying to press the chat. I'm sorry.
Oh, okay. That's all right.
Every time. I'm so sorry.
No, that's okay. We'll put your hand down then. Thank you.
Thank you.
If anybody else wants to raise their hand though and ask a question related to this, and then as we move forward into the open mic, we can also just open it up more broadly. No? We've got a lot in the chat, so don't forget to look in that because some folks have just shared their own experience with some of these programs. So I found that to be really helpful just to kind of keep an eye on. So if you haven't been looking in the chat, I really encourage you to scroll up.
I guess my only kind of like parting thought just from a panelist is, I think a lot of times I speak to people in the community or my friends or family or colleagues who are not involved in kind of the forensic aspect of things. And they feel a little intimidated on my behalf of this clientele. And I really just would encourage people not to shy away from working with this clientele. I've worked across many settings for a lot of years. And I actually find this the most rewarding clientele to work with. And especially if you're wired for it, lean into it because it's got its unique challenges, but I really appreciate working with the dynamics of this clientele.
Thank you. That's super helpful to get your perspective on that. It's very heartening to hear that it's very rewarding to work with this population. And I think it's good for everyone on the call to hear that too. We did have 2 more quick questions. I don't know if we could quickly do those. I know we are kind of running short on time. Lorna, do you want me to? Okay. So what methods of peer support and client check-in groups are used in making peer support available to clients? I know we touched on peer support. We may have covered it a little bit. So I don't know, Milton, if you've got if you want to clarify your question a little bit more. Groups, check-in groups? Do you guys have any groups?
We did pre-COVID. Right now, our peer specialist is nearly all one-to-one.
And we did have quite a few peers chime in on the chat earlier when we were talking about peers.
Yeah, I mean, we would have our Enhanced Illness Management and Recovery group, and that was co-facilitated by our peer and SUD specialists. So that is a group that our peer was involved with, but every participant on the team has access to working with the peer that works with the team.
Great. And there's a great resource that was just shared on the chat, Logan from Eugene. They tend to review a guide called Moving Forward with a Past. And this is more about going back to the housing question that was earlier, just in terms of a guide with helping with housing efforts for forensic and vault clients. So thank you for sharing that, Logan. That's awesome. And then let's see. And just to go back on who's on your team, do all of the FACT teams on the panel have a PO or a police officer on their team? I think.
Oregon does not.
No, but
Yeah.
what we do is we will invite a PO to a treatment team for
Yes.
someone that may not be doing what they're supposed to be doing. So, yeah.
Yeah. And then working collaboratively with them, but not necessarily on the team with the other, I know with the Minnesota teams, right?
Yeah, and they do outreach. We've done some risk management stuff in the community with ours.
And has it been challenging at all in terms of just a real different perspective in terms of, just working with this population? Are there translational issues that come up with that, or has it been?
No, actually, with
Okay.
ours, we've been pretty lucky. They're very motivated to do this, and they've had training in, I think, motivational interviewing, some other things. So the values are pretty closely aligned.
Great. Well, that was our last question. So any other final parting thoughts? We've heard from everybody on the panel, just making sure there was anything more. It was very comprehensive.
I would just say, unfortunately, there's just so much stigma out there for our folks that have criminal justice histories, and just taking a moment to acknowledge that is really hard work to do, but the participants are amazing individuals with so many strengths, and just the fact that everyone is really an advocate and just trying to share those strengths with the community to reduce the barriers that are out there. So there's just so much effort that goes into just bringing light to those strengths and putting the positives forth to reduce those barriers to housing and to employment and to just getting access to resources that other folks do not have barriers to. So thank you for all the amazing work that you all do.
Thank you for all the amazing work you do and all of the panelists involved today. Thank you. And I know we kept you a little longer than we said we would, but there was a lot to unpack, I think, today for this topic. We do have about 5 minutes just to open things up if anybody has any, open QA for you guys, if we're already shifting gears here. Just in terms of, yeah, go ahead, Lorna.
One small thing, because I saw Nicholas put this in.
I saw that.
So there was voice interest to try to connect the forensic team folks out there. And one way to do that, I'm sorry, I have a very attention-seeking cat next to me right now that's doing a lot of things. That's why I'm over here. So we have an app discussion forum. Justin, if you can put in the chat a way for them to get connected to that discussion forum. But we have a page set up for FACT. And if you guys wanted to utilize that to share contact information and pro tips, it's just a centralized space. So we'll hopefully get something in the chat for you all in the next few minutes.
Great. Yeah, I saw that. That's great. Sounds like there's a lot of coalescing and interest in some of these subgroups too, focusing on specific topics and populations within NAC. So that's great. Other questions? I think we probably have time for maybe 2 questions or anything that people want to raise, you can just quickly raise your hand or put it in the Q&A. Doesn't have to be about the topic at hand today. We usually try to have more like 20 or so minutes to do this, but again, today was a little longer just because it was a really big topic to cover and lots of presenters. Or even, you know, we've got going from potentially pandemic to endemic, anything related to COVID. As you know, we've in the past, that's been our focus on these calls. We've been trying to shift us kind of back into sort of ACT best practice, knowing that things are ebbing and flowing with the pandemic. Let's see, we got something in the chat. Oh, no, that's the forum link. Okay. Well, maybe we have tapped this group out for today. I think we may have. All right, well, while we're just giving you another moment here, just a reminder, as I said earlier, we've got 3 more calls that are part of this year's contract with SAMHSA for our MHTTC. We have our next one actually next month, as opposed to every other month since we skipped January. We've got Eric Granholm coming to talk about his model, cognitive behavioral social skills training. So this is a mix of cognitive behavioral therapy and social skills training, and it's meant to be very brief and easy to access, and something that ACT teams, that he's piloted with ACT teams specifically. So he's going to share with us his model and tools to do that. We know a lot of folks brought up social skills training and just, you know, dealing with psychotic symptoms is one of the big areas that obviously you're dealing with. And so kind of nipping both of those in the bud with this particular model. And then in May, so we are not meeting then in April. And then in May, on May 2nd, we're bringing Sarah Kapelovich here to talk about violence risk assessment. And she's going to touch on documentation in particular as part of that, because I know that question comes up a lot, like what can I put, you know, within the EMR, what, you know, how do I phrase that kind of thing. So she's going to focus on that. We're keeping July open. So that's where, you know, really giving us your thoughts on what you'd like to hear in these calls going forward is really important. I pasted in our evaluation link so that you can also put in your top ideas for that. We may need to do some polling as well in one of the next calls so that we can finalize that July topic. But we wanted to keep it open just to make sure that we were responsive to areas you want to talk about. So with that, we're going to close our call for today. But as you know, we post the recording, and so you'll get notification when that gets posted. Always, you know, don't hesitate to put stuff into the National ACT listserv. Lorna posted in here. If you haven't signed up yet, that's also a great place to get this information. We usually put information about these calls in there as well. Everyone on this call will get something from the Northwest MHTTC about future calls, as well as other work in this area that's not focused on ACT specifically, but certainly can enhance everybody's skills in working with ACT clients. So we look forward to seeing you guys in another month, and thanks for joining us this month. We'll see you soon.
Bye.
Bye-bye.
Bye.
Take care.
Bye-bye, everyone.